Also, we have conducted some of those services where in this month, a lot of patients, about 10, the Aphasia patients who have been earlier identified, we have all them, they also came, evaluated, lot of other the activities they have done, and we have guided them regarding the importance of the home parents and the family who can instill the part of their education throughout the area throughout the life. And also today we have conducted the early morning the quiz competition. I'm happy that our students have participated and they are done well and they are much concerned about these activities. So our professional activities, our academic activities, where they will carry forward in their life. I'm happy that today we are organizing a lot of and tutors and benefits of the district. Here is we are very experienced speaker from Dr. Srimati on the very important areas. They are associated one from the already the and one from SRM. Srimati. Ramachandran. Okay. So I welcome all of them and Nathan will speak about more about them. So once again, I welcome all of you for participating and celebrating this learning opportunity and hope that this kind of activities will carry out throughout the years and leading services. So services will require our professional activities. So I welcome all of you. Thank you. Thank you.
Thank you, sir. Now I would like to invite Professor N. Rajan, Dean and Director of Research to deliver the welcome address.
Very good morning, all of you. Good morning to all. First of all, I'd like to appreciate awareness campaign in the university. So also appreciate the department to bring in to scholars and they help Aphasia and this area. I appreciate Aish, welcome and extremely from understanding. Welcome for this program. I welcome Lakshmi, Dr. Sura, Dr. Jina, and all the faculties from the Department of Technology and all my dear students, the PG students, especially from Department of Study and the students from the program. I'm sure this will give a lot of insight into the important learners we are involved. And I also just request that Bonnie to create a little more awareness on dysphagia, especially when compared to Aphasia. In the medical treatment here, and prescribing at least in voluntary medical group that is our role in the dysphagia. So many people know that our role in this area. So when people are not having something the role in dysphagia, so maybe the next 1 year we can plan for such programs to create awareness among medical professionals so that we get more reference and they know that when we have something to give our expertise in this way. So with these few words, I have you all. Thank you.
Thank you, sir. Now, we will move on to the webinar. So the first talk is on assessment of quality of life and life participation approaches in the management of aphasia by Dr. Abhishek DP. Unprecedented changes are occurring in the way treatment for aphasia is being viewed and reimbursed. There has been a shift in perspective from treatment focusing on deficit area to choosing goals that produce meaningful changes in real life situations. Therefore, to familiarize us about this shift in perspective for the assessment and treatment of aphasia, we have with us today Dr. Abhishek DP, Assistant Professor in Language Pathology at the All India Institute of Speech and Hearing. Dr. Abhishek completed his post-graduation from JSF Institute of Speech and Hearing and PhD from All India Institute of Speech and Hearing. He is currently working as Assistant Professor in Language Pathology at IIT. He is also the Chair of Research and Training Promotion at Indian Speech and Hearing Association. He has also published more than 20 articles in international and more than 60 articles in national journals. He has authored and co-authored more than 100 conference papers. He has 10 years of teaching experience, and he has won 10 best paper awards at various national and international conferences. We are very happy to have you with us today. Over to you, sir.
Thank you for the kind introduction as well as hello. I hope I can. I hope you can hear me. Yeah. Thank you for your kind introduction. I hope I can share my slides.
Camera. Yes, sir.
Can you please stop the screen sharing so that I can share my slides? Okay, I hope you can see the slides too. Yeah, so here in this particular presentation, I will be covering two topics. One is on quality of life assessment, and the second one is with respect to life participation approach in the therapeutic rehabilitation of persons with aphasia. Okay, so first of all, you all know, I hope you're all bachelor's and master's level students or professionals working there. So you know what is aphasia. So when you say aphasia, it's like you can just put it like this. So it's the difficulty in understanding, speaking, reading, and writing, which is caused because of an acquired brain injury. The acquired brain injury could be a resultant of stroke, or it could be a resultant of, like road traffic injury, as in road traffic accident, as in traumatic brain injury, or it can be a consequence of tumor and other causes also. But what is the consequence of aphasia? Once a person develops aphasia, what are the consequences which the person is facing? So if you speak in terms of the research language, like you have independent variable and dependent variable, right? So in the same way, if aphasia is treated as an independent variable, what are the consequences? The consequences are treated as a dependent variables. So what are the consequences of, like aphasia, if we see? So first is loss of independence. So most of the terms are self-explanatory. So wherever it demands explanation, I shall give you the explanation. So loss of independence. So the person was the breadwinner of the family and the person was all independent, taking decisions on his own. And owing to aphasia, he has lost his independence. The second one is motor problems. See, like there are certain specific types of aphasia, like which can have motor problems, but that will evoke a lot of constraint on the, like person. The person will not be able to move about, and that will add to, too much of constraint as far as the person is involved. The next one is loss of job. So this is, like dependent on what kind of job the person has had. Like the person is employed with. So if it's a government job or something, the provisions change. But if like more in case of like the private job scenario, the job would change. Let's assume that the person was working in a BPO, that is a call center, or the person was working as a driver. So in such cases, like they may not switch the job. What they may do is they may remove the person from the job, so which can result in loss of job. Next is impaired relationship with family and friends. So like when you're not able to speak, like the dynamics of relationship also change. You cannot expect to have the same kind of relationship what you were having before. And the way the people see you, their perspectives on you also would change. And this can affect or strain the relationship with family and friends. So loss of self-esteem. Now that the person has, like developed a sense of inferiority, that he's not able to function like before, he's not able to earn like before, he's not able to talk like before. So this will result in the loss of self-esteem. The person will, like lose his self-esteem, and he cannot have the same sense of this is because of the sense of inferiority, which I told you right now. So the other consequences are as follows. Financial dependency. I stated earlier saying that the person was the breadwinner of the family in most of the situations. Now that, because of stroke, he's just confined to the wheelchair or bed. And owing to this, he has lost his financial dependency. And there could be marital issues also. Which can be a consequence of sexual incompetence, and they can have difficulty to attend social gatherings. See, like whenever you see someone, limping, or someone not able to speak properly, so what will happen? Your attention will automatically switch to that person, isn't it? So that will, make them more conscious, and that will give them a sense of, not being perfect kind of feeling. So because of this, they find it difficult to attend social gatherings, and the the most important factor here is the acceptance of self and family. So first of all, the person will be in the state of shock, anxiety, and even in the state of anger, and he may vent out his anger on the family members. So and the family members also, the family members also would, the way the family members would see this particular person also would vary, right? So, and inability to pursue hobbies. Suppose the person, was going to a gym before, the person was, having having activities which involves, was indulged in hobbies involving physical activities, he may not be able to pursue such hobbies further. And, other health conditions also, there may be complications related to the other health conditions also, which can add to the problem and make it more worse. So this is about, the consequences of aphasia. To just give you a quick recap. So first, I've just told you about what is aphasia, and then we've discussed regarding what are the consequences of aphasia. Okay, so next is assessment of aphasia using life participation approach. So even though I'm speaking about quality of life approach, I've taken the... Yes, please.
Got disconnected, sir. 1 second, sir. Sorry for the inconvenience, sir.
Yeah. Hello. Hi, Adima. Okay. 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 Sure. Just let me know when I can start again. Can I rest? Let me know when I can resume my presentation. Can I get back? Can I resume? ಅಮೂಲ್ಯ ಇನ್ನು ಸರಿ ಹೋಗಿಲ್ವಾ ಅದು? ಓಕೆ ಓಕೆ ಸರಿ ಸರಿ, ನಂಗೆ ಹೇಳಿ ಯಾವಾಗ ರೆಸ್ಯೂಮ್ ಮಾಡ್ಬೋದು ಅಂತ, ಅವಾಗ ನಾನು ರೆಸ್ಯೂಮ್ ಮಾಡ್ತೇನೆ. ಓಕೆ, ನಾನು ಇದು ಕನೆಕ್ಟ್ ಆದಾಗೆ ಇದ್ದೀನಿ. ಪುನಃ ರೀಕನೆಕ್ಟ್ ಆಗೋದ್ ಬೇಕಿಲ್ಲ ಅಲ್ವಾ? ಅಲ್ಲೇ ಕಂಟಿನ್ಯೂ ಮಾಡ್ಬೋದಲ್ವಾ? ಸರಿ ಸರಿ, ಓಕೆ.
Laptop ma'am, it is connected. We can start.
Sound good.
So வந்துச்சு. Wi-Fi 180. இதெல்லாம் இருக்குதுல்ல, அது ஒண்ணுமே இருக்காது.
So can you hear us?
Yeah, I can hear you. Can I resume my presentation? Can I continue my presentation? Hello, can you hear me? Hello, can you hear me? Can you hear me? Can anyone let me know if you can hear me? Yeah, fine. Yeah, fine. Thank you. Yeah, like I don't know at what point the connection got cut. So I was speaking regarding the consequences. Can you mute? Yeah. I was speaking regarding the consequences of aphasia. So I was just telling you that, there could be loss of independence, motoric problems, which would restrict the person's movement, loss of job. So based on the basis of what job the person was carrying out pre-morbidly, and it would strain the relationship with the family and friends. The person can, have financial problems because he's not able to earn like before, marital issues and sexual incompetence, which can interfere his sexual incompetence, which can interfere the person's marital life. Next, the person may feel awkward to attend the social gatherings. How the family members see him after the incident also matters, and the person will face difficulty in pursuing the hobbies. And adding to all this, the other health conditions which the person may face subsequently also would matter. Okay. So there is a little disturbance. Can you mute your mic, please? Yeah. So next we shall see regarding the assessment of persons with aphasia using life participation approach. So as I told you earlier, it's like the presentation I've divided it into two parts. One is regarding how you can carry out assessment and how you can use the same information in therapy. So this is the two parts. So I'll just continue from here. So when it goes to, assessment using life participation approach or assessment of quality of life, it goes beyond diagnosing the severity and pattern. So like you have some conventional tests as far as aphasia is concerned. For example, if you take WAB, it will tell you about the pattern, type of aphasia, and the WAB-R can also tell you about the severity of the condition, right? But when it comes to quality of life assessment, it is basically beyond that. So it assesses the overall consequences. How is the person getting affected, because of aphasia? How is the support system around him, and how people around him are, offering support, and how has his life changed post aphasia? So this is the thing which comes into picture when it comes to quality of life assessment. So it's beyond the conventional assessment, and it assesses for two things basically: how his life has changed post stroke and how is his support system operating. So these are the two things on the basis of which quality of life assessment is carried out. Right. So when it comes to quality of life assessment also, they divide it into two domains. One is functional assessment and the other one is communicative effectiveness. So when you say functional assessment, it is regarding different activities which the person is indulged in. It could be a telephone conversation, reading a newspaper, watching TV. As a consequence of stroke, how these things are changing is what you're assessing when it comes to functional assessment. As far as the other term is concerned, communicative effectiveness, it's regarding communication. Like there are some proponents who use the term communication confidence also. How effective is the person, like in putting his thought? So how, like whether, it's leading to a communication breakdown when the person opposite is not able to understand. How effective is the person in imparting the information is what you see in communication effectiveness. So basically, as you all know, so I take the result from the concept of communication, which involves a speaker, listener, and a media. So as a speaker, whether the person is successful enough in transmitting the message. So what he's speaking is in context with the situation or not, whether he's using the right pragmatic strategies or not, how efficient he is in delivering the intent. So these things would, matter. So like the situations in which the communication effectiveness is to be assessed is when the person is speaking to a group, when he is speaking to 3-4 people, there could be visitors, who would come to visit the person. When he is speaking to the person, the relationship would vary with respect to each of the person who's opposite in front. So the person should speak accordingly. So whether he's able to speak effectively when it comes to a group, when he is able to follow conversational rules. What do you mean by conversational rules? When someone is speaking, I have to listen. When it's my turn, I have to speak. So this is the basic rule as far as a conversation is concerned, and whether you're able to follow the conversation rules and whether you're able to follow it when you're speaking to many people at a time also. And to take part in a conversation about you. If someone asks you, what has happened to you? So, or what will you do further? So when you have to answer them, and to tell facts or events, the person would have gone somewhere and to a hospital for a visit. So, and did you meet the doctor, or what did the doctor say? In order to communicate such things to the family and also to others, so this is one situation in which the communication effectiveness is to be assessed. Next is to understand a joke proverb. See, all this are activities of daily living, isn't it? So when it comes to activities of daily living, whether the person is able to cope up with these activities is what you're seeing here. Next is to speak to people who are not belonging to the family. See, there are certain specific strategies which you have to use when you're speaking to strangers. So that's again a particular situation in which the communication effectiveness is assessed. Next is to express your opinions. This is very important. So the person was the head of the family and is to be considered as the head of family even now. So whether he's able to, tell his opinion, whether he's able to, express his opinion is what you have to assess for. Okay, so again, there are certain other situations also, like to understand when others speak, to explain yourself, to understand television programs. All these things, are the situations in which your communication effectiveness or communication confidence is to be assessed. This is yeah. So communication, yes. All these things are the situations in which all these things are the situations in which your communication effectiveness or confidence is to be assessed. Okay, so next we shall go with the quality of life assessment as per ASHA. So what ASHA recommends is when you have to assess for quality of life, there are different dimensions. But here, as a speech language pathologist, I have taken communication as a dimension. So according to the ASHA scale, so you have to determine the impact of communication disorder on adult relationship. That is, so like when you're speaking to your son, daughter, spouse, family members, boss. So what are the constraints which you're facing? So that has to be documented, is what ASHA says. So next is interaction with communication partners. So whoever the communication partner be. So whether, regardless of whether the person is familiar to you or, the person is not familiar to you, whether you're able to carry out your role as a speaker and, get your activities of, get your communication intent addressed and with minimum effect on your activities of daily. That's the second parameter as per ASHA, which has to be assessed. The third thing is the communication strength and weakness. So, you have to, as a assessor, so you have to assess for the communication strength and weakness. So there are certain techniques which would like, for example, if you're speaking about constraint induced aphasia therapy, it would tell you that you have to work on verbal communication itself. You have to constrain the other forms of communication. So you have to, like, in order to decide all such things, and there are several other approaches which tells you that you have to use multimodal communication. So you have to know basically what is the person's strength and weakness. So this is regarding the first part. So first, I'd like to just give you a quick recap of what I've spoken. So I've just told you about what is aphasia. Then we've discussed regarding the consequences of aphasia. So as per the LPAA, in order to assess persons with aphasia, it goes beyond the conventional assessment of, assessing the type of aphasia and the severity of aphasia. So you have to assess for two things in reality. One is the basic situations in which the communication has to be assessed, and next is how effective the person is in imparting information. So, and we also discussed regarding the 3 dimensions as prescribed by ASHA. So this is regarding the first part of the presentation. So next, if we just say, like, before we move on to the therapy-based intervention, we'll see what are the burden on the caregivers. So, first is it would impact the daily living. So if there is, a person who's not able to speak, who's not able to carry out the activities on his own, it would, of course, affect the other people in the house. And it can impact their daily living also. And, if the person is the breadwinner, so it can, affect their financial status also. And the responsibility transfer is the most important aspect here. So the person was the head of the family. Now he's not able to, carry out his role. So in such case, someone else, the onus falls on someone else who has to take up the responsibility. So that also falls on the caregiver, giving a burden to some of the caregivers. Next is, what is the coping up mechanism? So that is, like, when this person cries, there are certain types of aphasia. For example, if you take Broca's, they're well aware of their condition. There is no prosperinant nausea. They're well aware of their condition. They may just get emotional and, they may just cry. So how this family members have to handle him becomes a problem. And, yeah. So the next one is, regarding the, when you say coping up mechanism, it holds good with respect to, the coping up mechanism would be with respect to communication also. Now the person has turned non-verbal. So how should they cope up with the non-verbal communication? It can lead to confusions and communication breakdown many a times. So what are the coping mechanisms which they have to follow? So till they imbibe a particular pattern, it can impose burden on them. Next, it can increase the anxiety of the caregiver. Next is, it can increase the tension of the person, and coping up, I already stated, and consolidation. See, consolidation is a particular phase where the person, gets to know about the person. So like when an acute phase, that is when the person has just suffered a stroke, the burden would be relatively more. And as and when the person moves towards the chronic phase, what will happen? So they will know that this is how he expresses his needs. So this is how he behaves. So they will, consolidate. So these are the consolidatory mechanisms which they develop, but it may not be developed very earlier, but it may be developed later. So this, to conclude about the assessment thing, we need an approach which includes all these domains in assessment, be it functional assessment, be it communication effectiveness, be it communication breakdown, or, seeing from the caregiver's perspective and seeing what kind of burden it imposes on the caregiver and how to minimize the burden. So all this comes within the purview of the speech language pathologist to address these conditions in assessment. So hence I told you that it's beyond the conventional assessment and it has to tap all these parameters. So this is the first part of the presentation, which is on quality of life assessment. Can I address the questions later? Can I just continue with the life participation approach? Yeah. So yeah, when you say life participation approach, the basic assumption of the picture is, like life is larger than aphasia. So what does it mean? When you say aphasia is often viewed as a verbal problem, like the person is not able to speak properly, the person has, like articulation problems, the person has physical effort, the person is not able to understand. Because of that, like the person is not able to speak properly. This is the usual notion in front of people. But aphasia is beyond, right? So if you can see this particular picture, so like aphasia can affect the person overall. It's just not a problem confined to your brain, restricting your verbal communication skills, but it affects your family and it affects your social life. So aphasia has to be considered as a condition which is beyond, like the verbal deficits what the person exhibits. So when it comes to, the life participation approach, we shall try to understand what is life participation approach when it comes to aphasia, what are the core components, and the assessment part I've already discussed. So first is, when it comes to life participation approach, it acknowledges that aphasia is a chronic disorder with long-term consequences beyond acute disruption of communication. What does it mean? Like when a person suffers stroke, the person will not be able to speak. Slowly, the person would, like develop verbal communication skills. The person would be in a stage to speak, but it may not be 100%, but still, at least the person is, making an effort, but it may not hold good with respect to all the people. So there are certain cases where, the impact, where the size of lesion, it depends on the size of lesion, site of lesion, etc. If it's a very diffused brain injury, then you cannot expect the person to, resume the activities of daily living within months. So it may take, a real lot time to just cope up with this. And it is like, it is not that, like many a times when we counsel cases, so the first question what they ask us is, how long does it take for the person to recover? So whether the person will be able to, cope up his activities like before, whether he'll be able to earn like before, whether he'll be able to resume his job. So these are the common questions which we consider, which we address during the counseling session. But here, when you speak about what does it mean is, aphasia is a chronic disorder. That is, even after the person recovers, there will be some amount of residual deficits. So the person may not be able to speak as quickly as the normal counterpart, or the person may not be able to, like the person's intelligibility may be a little compromised. The person may require, like the instructions to be repeated in order to carry out any particular task. So aphasia imposes a lot of impact, and you have to see that there will be some residual impact also on aphasia. That is, the person, will have some problems even after recovering from aphasia. So that's one of the basic assumption of life participation approach. I've already told you the other assumption, which assumes that life is larger than communication. So the second one is, you have to treat aphasia as a condition with long-term consequences. It's not that, like within 3 months, 4 months, 6 months, the person will recover completely. The person can recover, but even in spite of recovering, the person can have residual deficits. That's what, like I'm trying to tell you. And that's what the life participation approach also acknowledges. Life participation approach is a consumer-driven approach, delivering with the philosophy that you have to maximize the re-engagement in the life of persons with aphasia. There are two keywords here. One is consumer-driven service. So what does it mean if you see? So there are certain approaches which are clinician-driven, okay? So which tells you how the queuing, for example, if you take something like semantic feature analysis, or, the PCA, the phonemic component analysis and all that, it tells you that, okay, so you have to give a category coordinate as a Q. You have to give a rhyming word as a Q in PCA. So there are certain specific steps which is to be followed, and it is more a clinician driven approach. But here, on the contrary, life participation approach is more consumer driven. That is, it tends to view aphasia and it tends to treat aphasia from the consumer perspective, that is from the person with aphasia and his immediate family perspective. And here there is again a keyword, which is maximizing re-engagement. See, like aphasia is a condition in which you relearn language. When you think about the patient's perspective, or if you are speaking with respect to the clinician's perspective, you're reteaching language. But here the term to be used is re-engagement, for the person to, like revoke the life, or for the person to reinstate his life like before. What are the strategies which is to be followed is what your life participation approach advocates. Okay, so it's a consumer driven approach, and it believes in re-engagement rather than reteaching or relearning language. So in spite of linguistic gains, many people with aphasia exhibit residual deficits. I already told you. So like, for example, like there are some cases which tell us that they have problem when they go to bank, when they go to some specific places, they have problems. So one is, like they become more conscious. Second, they may not know what are the words to be used. And, like sometimes their speech may not be intelligible enough in order to convey the information. So there is, even in spite of you working on therapy techniques which can improve the linguistic skills of the person can have residual problems. Okay, so this residual problems would last a lifetime, and so a life participation approach believes in addressing this residual problems also. Untreated and unrecognized psychological and social problems can cause disability, diminish community reintegration, and reduce response to rehabilitation. What does it mean? So, like, if you don't consider the individual as an individual and treat him as a patient, so what is happening? You're, as a speech language pathologist, you're trying to improve his linguistic skills. Well and good. But are you trying to understand from his perspective, what are the constraints which are induced because of aphasia? And, what are the constraints which is induced in case of, what are the constraints which is induced in case of aphasia? Whether the person is getting his needs satisfied, whether he's able to, speak to his, group of people. So all these things can have an impact on the person, isn't it? So when such things are not addressed, if your focus is just improving the linguistic level of the person, so it can affect the person. So it can psychologically affect the person, as what the life participation approach believes in. And one of the goals of life participation approach is to promote membership in the communicating society. So what does it mean? So, all of you would have heard about disability, impairment, disability, and handicap. Okay, but our understanding is just confined to these terms, but we don't see, we don't give that much emphasis on the handicap part of it. Whether the person is, the person, let's assume that the person was going to a recreation club before. Now he's not able to go because of his condition. So that can affect the person when he's not able to, do some things which he was doing pre-mortem. Isn't it? So the person was, a teacher, and he was teaching a group of kids at home as a part of tuitions, and that used to give him money as well as pleasure. So now, because of the condition, he's not able to do it. So it can affect the person psychologically. So when you're not so LPA believes that you have to treat the person in a larger, larger domain rather than confining to his linguistic needs. So that is one other goal of LPA. There are some core components as far as LPA is concerned. The first one is to enhance the life participation. So because of aphasia, the person's participation is restricted. And what you have to do when you address this therapeutically is to enhance the person's life participation. That is, the person should be able to, involve himself in all walks of life, so which will increase his participation. All those affected with aphasia are entitled to service. Later, probably in the next or the other next slide, I'll just tell you who does it refer to when you say that all those. So when you say all those, what we feel at the moment is it is just the person of with aphasia alone. But there are other things also like which we have to take care. How the family members are trained, how the like other members in the family are trained. Even that also has to be paid weightage to minimize the social problems which like aphasia can give you. So next thing is like the second part of the component, second core component of LPA is all those who are affected with aphasia are entitled to service. The third one is personal and environmental. The ICF model also speaks about the same. That is, the personal and environmental factors are to be taken into consideration. So whether the person was an introvert or an extrovert, whether the person has a has good motivation, whether he has a positive attitude, negative attitude. So how are the people around him treating this particular condition? Whether they are evoking any negative behaviors in the person or are they encouraging the person? So all these things is to be paid weightage as per LPAA. And next is success is measured via the documented life enhancement changes. So when the person suffered stroke, what was his quality of life and how was his quality of life now after 4 months, 5 months, 6 months, after a year? So that will tell you about the success of a particular therapy technique. So the yardstick for therapy here, sorry, the yardstick of success here is not regarding whether the person is 100% intelligible or 80% intelligible, or whether the person uses all the strategies, whether he's not getting any word finding difficulty. That is not the yardstick to measure therapy. LPAA says according to LPAA, the success of the therapy technique lies in what is the life enhancement changes. That is, they use the term enhancement before also. So that is after you involve the person for therapy. So what are the changes in the person's life, whether he's able to cope up with the social scenario. So that is to be taken as a yardstick in deciding the therapy of it. Success of a therapy technique is what it says. Emphasis is placed on the availability of services at all stages of life. So one more thing what we do is we have a notion saying that in the acute phase, if you give therapy, the person will recover. So it's not it's not that it is false. It can be true, but it should not undermine the fact that people who are beyond acute phase also would have their own needs. They also would require some therapy. So that has to not undermine this fact, right? So the according to LPAA, as emphasized on the word residual communication deficit, every person, regardless of whatever stage he's in, whether he's in acute phase, clinical phase, consolidated phase, or the chronic phase, you call it as. So all these people would have their own needs, and the emphasis is required for therapy is required for all these people, regardless of the phase they are in. So that's one more, key component as far as the LPA believes it. And when it comes to, there was a term here saying that personal and environmental factors is to be taken into consideration. What does that mean is elaborated in this particular slide. So first is physical, psychological, and emotional changes as a consequence of aphasia. So what are the physical constraints? What are the psychological constraints, and what are the emotional changes which the person is handling is to be taken into consideration. Physical, it's very easy because you can see the person. It's a visible type of disability, so you can get to know what are the physical problems which the person is facing very easily. But when it comes to the other dimensions, that is psychological and emotional, it is something which you cannot see. It is something which you have to which is inherent in the person, and it is not visible in the naked eye. So such thing has to be paid emphasis, is what the personal and environmental factors emphasizes. Next is the physical and social structures outside the body. For the person to communicate with the society, what is needed. So what are the what are the difficulties which the person is facing with respect to social communication, and what are the things which is to be done in order to come out of this particular problem is to be taken into consideration. Next is attitude of the society and the system. So what does that mean? So if the person lacks knowledge, if let's say that there is a person who lacks knowledge, so the person may cry in front of this person, or the person person may just, tell things which, which may negatively motivate. Like the person may just say that you are, so good, you are, you are so good physically, you are speaking so proficiently, now you're not speaking at all. So such factors will, morally put the person down. So, you have to consider, you cannot, go and counsel each person who's involved, but at least they have to be taught the way in which they have to communicate with this particular person with aphasia, and they have to have minimum knowledge of what the person is undergoing and what is their role in rehabilitation. So that's again a particular factor which is to be assessed and also addressed in therapy. So this is a very important, term which they use. So what are the factors which you have to consider from disabling to enabling? That is, the person has been disabled because of stroke and other conditions. So in order to enable, in order to re-engage, in order to put him back to work, in order to put him back to, in order to make his role more active, what are the factors which is to be taken into consideration? Is also to be assessed as what, LPA believes. And there was one more term here which requires elaboration. So there was a term saying that all those are affected by aphasia are entitled to service. So what does that mean? So when you say all those, whom does all those refer to? Is it just the person with aphasia alone or anyone beyond? And what kind of services are they entitled to? If you see in terms of life participation approach, when you say all those, it refers to the person with aphasia, it refers to the family members, it refers to colleagues, it refers to friends, it refers to neighbors. Like you may just ask me a question, how practical is it to involve all these people? So it may not be practical to just give therapy for 20 sessions to each one of them mentioned here. But, the family may require more, sensitization regarding the particular person. But at least if you can just address what is the condition which the person is undergoing to the colleagues, friends, etc., their attitude towards the person also will change. The way they speak also will change. Influence the person that can facilitate the person further. So, the emphasis, I'm not saying that the emphasis is equal. So the emphasis, of course, is on person with aphasia, and you have to give more emphasis to the person with aphasia. Later, you have to give emphasis to the family, because the family also should know what the person is undergoing. Why is the person not speaking? Why is the person getting anxious? Why is the person getting frustrated? So they should know all these things. And the other ones in the society, which connected to the person, of course, also should be addressed. When you say all those, what are the kind of services? And of course, the other health practitioners also should know what kind of problems they would know many times, but it would be better to know. Next is, when you say everyone is entitled for service, what is the service? One, we say that speech language therapy. Apart from that, counseling is one thing which is required. And we also have a notion saying that counseling is a one-time process. We do it immediately after assessment in order to tell what is the condition of the person and what is to be done further. But it is not so. So counseling is an ongoing process, and you have to identify what is wrong at each stage, and then you have to address that at each stage. Next is couple therapy. So basically, if there is any, problems between the individuals, there are many instances where, individuals with stroke are divorced, and, their spouses may not cooperate, or their, so in such cases or scenarios, couple therapy may be needed. And group training. So this is one more technique which is gaining popularity. So, see, if you just see the Western literature, it tells you that even in the earlier 2000s, there were approaches where people with aphasia were made to speak with other people with similar conditions. When you do so, what will happen? So they will get the feeling that I'm not alone. There are other people also facing similar conditions. So this can be of help to improve their mindset. So group training or supported communication, it is called as, is also a part of therapy. And I'm happy to say that you have most of this in the hospitals and other places now. So people are aware that when you expose them to group training, so even though they say that group training may not give individual attention, rather than individual attention, I'm not saying that individual attention is not required. Individual attention also would be required, but in addition to the individual attention, so knowing that there are other people in the world with similar problems, interacting with them also can be of help, and it can be of greater help when it comes to persons with aphasia. And there are certain support groups which is meant for the same, so that also has to be taken into consideration. As I already told you, success is measured with respect to life enhancement. So how was his quality of life immediately when the person suffered stroke, and how is it now? So that has to be taken into consideration, whether the person, what were the activities which the person was indulged in before, and what are the activities which are limited because of stroke, and what are the activities which the person is able to do now after re-engaging the person. That is to be taken into consideration. So whether his social connections have diminished because of aphasia or it has remained the same, that also has to be taken into consideration while you document the success of the therapy technique. Next is what kind of feelings the person has, regardless of whether the person has, like I told you that there is loss of self-esteem and there is a negative feeling in the person, whether you're able to wipe out such feelings and replace this with positive feelings also is to be taken into consideration while you, address therapy. And next is satisfaction. So how satisfied or contented you are also is to be taken into consideration. So this are the references which I've used in preparing my presentation. Thank you. If there are any questions, I would like to address them.
Hello. Hello, sir.
Hello, yes, please.
Thank you for your insightful lecture, sir. So we'll always remember the key sentence that you told that life is larger than failure, and start looking at the person holistically rather than only on the communication patterns, and hope our treatment shifts from more of clinician centered to more vaccination. So are there any questions from the audience?
Yeah, thank you.
So there is a question.
Yeah.
Good morning, sir. My question is, with respect to group therapy for patients with aphasia, how the groups can be formed, sir? Like based on type of aphasia or severity, how the groups can be formed?
I'm not able to hear the question properly. Would it be apt if you can type the message just by using keywords, because I'm not able to hear the person completely. Would it be feasible to type the question so that I can address it?
Sir, are you able to hear us now?
Yeah, better.
Sir, my question was, in group therapy for aphasia, how should the groups be formed?
How should the groups be formed, is it?
Yes, based on, is it based on severity or?
Yeah. I got your question. See, there are two notions also. When you group people, you have to consider people who are like-minded, people who have the same condition. But aphasia is heterogeneous, right? So you cannot have people with the same severity, with the same type of aphasia. So those factors, are a little immaterial. See, when it comes to how much support you're extracting from the group is dependent on these facts, but you cannot, form groups on the basis of all these conditions. If you take a condition like hearing impairment, you can group, the individuals based on whether there was early identification, what is the type of hearing loss, what is the severity of the hearing loss, when the intervention was, planned. All those factors to be taken into consideration, and group therapy can be planned. But here, I think those factors, you cannot be that specific while you form or constitute a group when it comes to aphasia. And but what the ultimately, it depends on what is your purpose. If you want to enhance communication, then it is better to group people with similar linguistic problems. If your intent is just to make person, aware that there are other people also, in the world suffering or encountering with the same kind of problem. So your intent there would be to group, to just export, to make a group out of, to make a diverse group consisting of people with different conditions. So, it depends on what your intent is, and it is very difficult to streamline or confine to some factors while forming group. But if your intent is to improve verbal communication, of course, then you have to form groups considering the type of aphasia and type of impairment, which type of verbal language problems what the person is exhibiting. Are there any other questions?
Hello, sir.
Hello.
Sir, there is one more question.
Yes, please.
Sir, there are additional disabilities along with aphasia, such as hearing impairment or vision problem. How would life participation approach work with them?
See, it should acknowledge all the conditions. So, for example, let's say that, as you mentioned, there is hearing impairment. So when you consider the person, consider the individual, consider the problems, what the person is undergoing, you have to integrate that particular factor also. So when you're designing a communication strategy, when you're, designing some communication strategies to prevent communication breakdown, so probably you have to use more of, you have to use nonverbal communication also as an adjunct when you're speaking. So considering what kind of problems the person has, you have to incorporate that to minimize the problems. So it doesn't, life participation approach doesn't tell you that you have to integrate, but generally when you think, you have to integrate that particular factor, and when you're designing strategies or when you're treating, that is to be taken into account.
Hello.
Hello.
Sir, thank you. There is one more question. Is there a difference between quality of life assessment and enhancement, life assessment of life enhancement?
See, technically, no. Because when you carry out a quality of life assessment itself, you will get to know what are the strategies which is to be followed for life enhancement. Or if your perspective is to assess for what are the strategies which would require enhancement, you will have to depend on quality of life measures. So technically you cannot differentiate the two. It's like when you carry out quality of life measures, you will get certain things which you have to address in order to enhance one's life. So I don't find any specific difference between it.
Thank you, sir. And there is one more question. Can quality of life measures be used to monitor progress?
Yeah, see, it is like a baseline, and you can, for example, I'm doing something at the baseline. Okay, so then what do I do after a period of 6 months, 9 months, 10 months after involving them in group therapy or after using life participation approach? I can carry out the same. So that can tell me how the quality of life has enhanced since then, right? So the quality of life measure, it's not like there is no hard and fast rule that you have to administrate only once, twice, etc. So to see what all changes the person is undergoing, you can administrate periodically. So if not very frequently, so you can just administrate on a later go also to see how well the person has moved with or how well the person has consolidated this condition over time. So it's not a one-time process. It can be done periodically to track changes.
Hello.
Sir?
Dr. Abhishek.
Yes, sir.
Dr. Arun Manik here.
Good morning, sir.
Very informative information, good lecture, where our students, even many students from other colleges also joined online.
Yes, sir.
So, you know, once the person develops aphasia, life is really become miserable. A vehicle cannot move without gearbox. Totally lost. We require rethinking to our physical structure, mental structure, to make it your lifestyles into the mainstream. If you see the government of India, the RPD Act, though it has been notified, aphasia can be considered under disability. The skills are required when the persons become aphasic. He himself lost their address, careers, opportunities, everything. Families ultimately suffering, and family also cannot give support because of the financial and economic problems in our country. The government of India has, though have been talked several times, provisions have been made, but skills required how to support with using the aids and appliances when they have other associated disabilities. This is the problems that are happening. Required in our country an aphasic home to support services. In this regard, what is your opinion when you talk about all the therapeutic management approaches? This is one part, but practically, when the life has become miserable, how to bring them into the mainstream services in our society still a question. We're not able to come out or making the demands or answer. These are the issues in our country. What is your opinion?
Yes, sir. So thanks for mentioning about the PWD Act. So when it comes to that, they just use the term equal opportunities and leave it there. But for this people to get equal opportunities, what are the efforts which is to be done? So that is nowhere mentioned or nowhere explained. And again, when it comes to equal opportunities, we have to understand what all hurdles are there or what all things are restricting equal opportunities. So from the person, from the family's perspective, from the societal perspective. So though it is easy to just say that, you change everything, but it is not easy when it comes to practicalities. Like, for example, if I'm dealing with the person and the person's family, they can understand the seriousness. But if I'm just treating a third person, say the employer or the boss of the person, and just trying to tell him what the condition is, it may not, it may not mean it cannot create an impact on that particular person. So our mindsets in which we see aphasia also has to change, sir, and we have to improve the the sensitization part is very much required. For people to understand what is it like when you switch, when you think in perspective of a person being affected with aphasia. So that requires a greater work at the societal level also. So because somewhere in the slide I just mentioned saying that for people to know about this, there should be more knowledge and awareness. We feel that knowledge and awareness are trivial terms. Say we are in 2023, everybody will have knowledge and awareness. They may not know what are conditions they may be encountering. So that's the only thing, the improving the sensitization measures, and also involving them in therapy, and just trying to tell them what are the conditions which the person is undergoing, what are the restrictions which the person is facing, also play a very important role. But as far as the Indian context is concerned, such things, sir, are at a very premature stage. Like there are certain therapy programs. If you see case reports in the Western countries, they say that a number of sessions addressed for the family, 4 number of sessions addressed for the colleagues in the office, 2. So, but do we do that? No. So we feel that, if we address the person and address the immediate environment, that is adequate. So I think we have to, change our approach, and people also have to develop that mindset in order to understand what people are undergoing, what people with persons with aphasia are undergoing. So, thanks for the question. So I think your mic is mute.
But one thing is that we are not really propagating. The family members or the person becomes disabled, though their legal provisions have been made by the government of India. We are not educating the family members how to go about the disability certifications and where to apply to getting the facility for these populations. Totally, this part we are ignored about. Our course, when we talk about teaching our students regarding rehabilitation of person with aphasia. At the same time, it is also required that we have to educate the parents, family members of the individual who are suffering from aphasia. They should go for disability certification, and they should also apply wherever the facilities, including the pensions, disability pensions who are already being suffered from aphasia. So those are the things I think being a All Institute of Speech and Hearing or any other colleges where the educational programs is going on, we need to educate, we need to work on this area so that now the larger benefits, all these populations can be larger benefited. So sustain the rest of the life. Isn't it? Am I right? And there is an opinion in this regard from your side?
Thank you, sir. There are 2 more questions, if you don't mind taking up.
Yeah.
Hello?
Yes, Amulya.
Sir, there are 2 more questions, if you don't mind.
Tell me.
Sir, there is a practically oriented question. There is a patient with transcortical sensory aphasia, and she is not willing to get out of her comfort zone and participate in group activities. So, practically, like, what can be done with her to improve her quality of life?
Yeah. So see, like each person is individualistic, like some people may be introvert, they may not they may not like to mingle with people. So there are certain problems, but like individual counseling and counseling the family members also regarding it, and even the family members motivating or pushing the person to be a part of therapy. So these are some strategies which you can follow. I assume that you would have already done that, but it has to be done in a more intensive manner, and the person has to get the mindset that, okay, when I have to improve, I have to incorporate these strategies. So that's when that's when you have to that's what you have to do in this particular case. So more intensive pushing is what is required, I feel.
Intensive counseling is what you recommend for her.
Yes.
Okay, sir. And the last question is, are there any Indian-based quality of life assessment measures? or tools?
Okay. So there are a couple of studies as far as the stroke and aphasia quality of life scale is concerned. There is something called SAQOL, that is stroke and aphasia quality of life. SAQOL. So I'll just mention it in the chat box here. SAQOL. So this was originally developed in 2003, but it has been adapted in the Indian context also by Kiran and Gopi Krishnan in 2018. So that you can just go through the particular material to see what are the parameters. So the Indian version, I mean the Kannada version, is developed by Kiran and Gopi Krishnan in 2018. So it's been published. You can just go through this particular material. And what I've mentioned in the first line, SAQOL 39, is a 2003 published study.
Are there any more questions?
And there is one more called as VSAT, but that is not published, so I did not specify that. But this is a published study. You can go through that.
Thank you for sharing your knowledge with us, sir, and very big thanks for your time.
Thank you.
Now we'll move on to the second lecture.
I'll just stop sharing these things. Just
Hello. Ma'am, can you hear us?
Yes, yes, I can hear you. Can you all hear me?
Yes, ma'am. We can start.
Okay. Thank you, everyone, for this opportunity.
Ma'am, we would like to introduce you. Before you start.
No, I can introduce myself, no problem.
No, ma'am, we are prepared.
I'll introduce myself.
No, ma'am, we'll introduce you. Dysphagia, as we all know, refers to difficulties in swallowing due to various etiologies. Early detection of dysphagia can reduce associated medical sequelae, subsequent burden of care, and also leads to better prognosis. As most patients admitted to acute care services present first via emergency department services at hospitals, timely involvement of SLPs may improve patient and service outcomes. To date, however, there is limited knowledge of the nature of assessment and management procedures in acute care patients. So today, our speaker, Ms. Srimati Narasimhan, is going to talk about approach to patients with dysphagia in acute care and comparing and contrasting them with patients who require long-term care. Ms. Srimati Narasimhan is a renowned speech and swallow specialist in Chennai with outstanding academic records from pioneering institutions. She is currently associated with Dr. Birla Institute and Medical Center, Chennai. She has vast experience in working in renowned international hospitals in Chennai for over 10 years. She is highly specialized in treating disorders of swallowing of neurological origin, brain and spine trauma, head and neck cancer, etc. She was the first SLP to initiate and successfully run programs to assess swallowing using state-of-the-art techniques in Chennai city. Her areas of interest and research includes cognitive neurosciences, neuroimaging, nuclear imaging in patients with Parkinson's disease, stroke, oral and pharyngeal cancer. She is also an active member of the Indian Speech and Language Learning Association and Indian World Federation of Neuro Rehabilitation. She has served as a resource person at several national workshops conducted across the country. She has conducted clinical educational programs trained students and professionals. There are also several publications in national and international peer-reviewed journals to her credit. We welcome you, ma'am. Over to you, ma'am.
I'm sorry. Yeah, thank you. Thank you so much for the wonderful introduction. And I would like to extend my heartfelt thanks to N.D. Rajan sir, Arun sir, and the whole team. Lakshmi Priya, Roshni, and Amulya. All of you all working in putting up this program here today. I hope I'm audible. Thank you.
Yes, you are.
So the topic that has been given to me is something that I have been doing for over 10 years now. So dealing with patients, taking care of patients who are in the acute phase in the ICU, who have survived multiple injuries, who have survived a stroke, who have survived other issues which can eventually lead to dysphagia. So right now I'm associated with Dr. Ella Institute and Medical Center, Krompet, Chennai. We are a 450 bedded hospital, and it was started off as a liver transplant hospital primarily because Dr. Ella specializes in liver transplant, and he is one of the world-renowned liver transplant surgeons. And I'm proud to say that Center for Hearing Communication and Swallow Sciences is one among the 45 specialties which are right now functioning inside this hospital. So my colleague, Dr. Abhishek, actually did a fabulous job. He explained about, how to focus on the life participation or life satisfaction and just not look at the person as such. You should look at what are the impacts that a person can have in his environment and what the environment can have an impact on the individual as such. So in a similar note, we all have heard of this term dysphagia, and we've all been treating patients with dysphagia. So I'm just going to quickly run through. I'm not going to talk about what is dysphagia. I'm not going to start from that. I'm going to go straight to understanding why are we talking about dysphagia and what exactly it can lead to. Why are we so much concerned about dysphagia? And there are so many programs that are coming up in our country now, and fellowships on deglutology, dysphagia, therapy, and all of that. So if you look at the complications that are associated with dysphagia, is first, we've all heard about this term aspiration, which is like a real monger where we all keep saying that the patient might aspirate, So that is one thing. And this aspiration can again induce pneumonia, which is a form of a lung infection. And this can also lead to a lot of delay in the resumption of oral intake. So you put somebody on a tube feed, or you've asked the person to be on tube feed for a certain amount of time. The whole intake is going to be slightly different from how they're feeding orally. So this is going to take a long time for them to resume their oral intake, which can eventually lead to malnutrition. They feel so dejected about being on the tube feed. They're not able to enjoy a sip of water or a sip of coffee, which can again have a greater impact on their quality of life. Also, so many instances when we have come across that, we are put in a situation where we keep these patients in the ICU or in the hospital for a longer duration, thinking about the tube. This patient is on tube feed. Let us just see until how long, he might need this. Is it okay to discharge him now? He is on tube. Let's wait and watch. So that way they're going to be in the ICU for a longer time or in the hospital. That is again going to be a burden on the family because it's going to involve a lot of cost, finance, and all of that. And this can also lead to increased morbidity and mortality. So if you look at the physiology of swallowing as such, so what exactly is going on? We know that, as you keep the food in the mouth, the lips close, the jaw opens and closes to, chew the food, and then the tongue is helping in manipulating the food laterally from anterior to posterior. The base of tongue is elevated so that there is no spillage of food. And then as the food is ready, the anterior part of the tongue goes up and then pushes the food backward. Then the pharynx acts, the swallowing reflex happens, the airway closes, the upper esophageal sphincter opens, and then the food goes inside. But what exactly is going on? How are these coordination happening is because of the cortical and the subcortical structures. So, fMRI studies have evidently noted that, frontal parietal operculum has a major role in initiating the swallow, and also the insula, the deep-seated structure called the insula, is also very, very important in swallowing. This is what the fMRI studies have documented. And looking at lesion studies, so depending on, where the patient had the lesion and what kind of symptom the patient is showing, it is also understood that it is not just the primary, secondary, primary motor cortex or the premotor cortex. It is also the subcortical structures such as the limbic system, the basal ganglia, and the thalamus, which are more like the relay stations. They also have a major role in swallowing, the normal swallow that we do. So the corticobulbar fibers from the cortex, which reach the brainstem structures, and then the swallowing centers such as the nucleus accumbens and the nucleus ambiguus, and then the nucleus tractus solitaris, which in turn supply, have the cranial nerves originating from them, which in turn supply the structures that are necessary for swallowing, is what is the physiology behind a normal swallow. So if you see what happens in a critical illness, so if we are talking about acute, that means the patient comes immediately to us. So the patient reports saying, I have been having this swallowing issue for the last 3 hours. We immediately take the patient, and then the neuro team is involved, and then they're taken to the MRI. We try to understand what exactly is the pathophysiology behind this particular issue. If it's so acute, the first thing that we're looking at is a stroke. Or if it is of unknown origin, we are trying to look at what could be the other causes. So if you see what kind of an impact these issues, for example, a traumatic brain injury or a stroke or an inflammation or delirium or drugs can cause, are mostly on the cortex and the brainstem swallowing centers, because it generally affects the sensory input, in terms of what kind of the input that the signals are being received, and then what is the organization that is happening at the level of the brainstem, and then what information goes to the motor nerves, which are in turn supplying the structures involved in swallowing. It could also be due to a direct trauma. It can be an intubation trauma. It could be because of the Rein's tube. It could be because of a esophageal, transesophageal endoscopy that's done. It could be because of an upper GI endoscopy. During the procedure, there can be trauma. It could be an emergency. Patient needs an intubation on an emergency basis. We can't be looking at, is it going to cause trauma? It's like a life-saving thing. So whatever is life-saving sometimes costs with all of these things also. And some of the patients can be admitted in the ICU for a longer duration, which leads to, immobility. They have limited mobility. They have multiple issues, multiple systemic issues, multiple issues in terms of respiratory inefficiency, the motor inefficiency, the neuromuscular junction. So many of those aspects which can again lead to what is called as the critical illness polyneuropathy. And some of these patients can also acquire ICU-acquired weakness or illnesses. And these can also be due to one of the most common things that we see today in our day-to-day lives is laryngopharyngeal reflex or gastroesophageal reflex. So how these affect, what is the level that these impairments cause, is very important for us to remember. Because as we go and see a patient, we are not just looking at the structure. The tongue is deviated. Immediately we should think, is it cortical or bulbar? Is it lower motor or upper motor neuron? Is it just the peripheral weakness? I don't see a weakness as such, but it is to do with the patient's effort. Is it something to do with ICU-acquired weakness, or is it something to do with the peripheral nervous system? So central and peripheral difference has always played a major role in decision-making regarding where the pathology lies. So if we see continuation of that part, where, we're more focusing on oropharyngeal dysphagia in general. So it can be due to a severe neurological impairment, which is affecting the central nervous system, such as, we see stroke, which is a cortical stroke or a brainstem stroke. It can also be due to multiple sclerosis, where you see some sclerotic patches inside the brain. The white matter tracts start getting affected, and or it could be due to amyotrophic lateral sclerosis, where the you find bulbar weakness more often in amyotrophic lateral sclerosis. And it could also be due to traumatic peripheral nerve damage, or an impaired function of the neuromuscular junction, for example, like myasthenia gravis, and a primary muscular disease. And it can also be due to a structural damage, that is trauma caused by an intubation, or due to a malignancy, post-surgical, or a medication or a toxic drug side effect, presbyophagia, which we will be talking in the end of my presentation. And it could also be due to the fear of swallowing. Sometimes these patients are so fearful, they have so much of, mental or cognitive issue that they completely not accept oral feeds at all. So one of the important things that we are going to discuss today is the post-extubation dysphagia. Intubation is a life-saving procedure which is done to establish airway in patients who have compromised airway. The intensive care physicians or the emergency medicine physicians put a tube through the mouth which passes through the vocal cords, and then it goes to up until the trachea, so that the airway is completely secure. So after intubation, once the intubation is taken out, it's called as the extubation. So post-extubation dysphagia is one of the most common things that we see in the ICUs. It can happen to anybody. It need not be a person with stroke. It can be even a person who has undergone a surgery. Patient has had 24 hours of post-operative intubation, and he was extubated after 24 hours. The patient can have dysphagia, swallowing issues presenting in the form of difficulty swallowing, or choking or coughing episodes with hoarseness of voice, constant bouts of coughing, change in voice, and all of that. So this intubation can have a direct trauma. It can cause direct trauma because of the endotracheal, and sometimes because of the tracheostomy tubes also. Because of this, it can also lead to neuropathy, leading to muscular weakness. Constantly a tube is through the between your vocal cords. You are all the time sitting with the tube between the vocal cords. If that goes for more than 48 hours, 72 hours or more than that, it can lead to muscular weakness, of the pharynx and the laryngeal muscles also. Because of the presence of the tube, it can also diminish the laryngeal sensory function, which is why post-extubation, patients might have very weak cough. And it can also lead to impaired sensorium, which can again, have a direct reflection about the centrally located problem. So patients, who are on intubation are normally kept under sedation. Nobody would want a tube through the mouth. They cannot be lying comfortably with the tube through the mouth. We all know that the cough reflex can actually expel the tube out, but they are kept under sedation so that the reflex mechanisms are generally kept under control. But this can also lead to some sort of an impaired sensorium, which can have a direct impact on the sensorium and the cognitive functions, which is more of a centrally located problem. And another important aspect is the gastroesophageal reflux. And post-extubation, patients can have a desynchronous breathing and swallowing. So we all know that swallowing and breathing have to be in synchrony for us to be able to efficiently swallow. They can be desynchrony because of any kind of weakness, because this tube is going to be constantly giving a pressure on the vocal cords and the surrounding structures. It can lead to a sensory weakness and sometimes even motor weaknesses. That's what we're going to talk about now. So these intubation tubes can cause trauma because these are artificial tube. It can cause trauma to the directly to the anatomical structure. This is one of a very interesting image I found. So, it completely tells about where exactly the trauma could happen, where the tube can pressurize and what kind of a change. So if the tube pressurizes over here, it can lead to edema. If the tube pressurizes anywhere over the thyroid or the cricoid, post-cricoid region, it can lead to even dislocation of that area. And constant pressure on that area can also cause necrosis and granulation of tissue, like you can see here below the level of subglottic area. And sometimes it can even cause tracheomalacia. We've had such patients, especially in young babies. And sometimes many times we've also seen true vocal cord weaknesses because of laryngeal nerve palsy. And also edema, stenosis, granulation, and paralysis are more common. Because of the intubation causing a direct impact on the mucosal tissue, it can lead to mechanical irritation and also triggers, ulcers and inflammation. And one of the other important things that we need to remember is cuffed airway tubes. the intubation, the purpose of putting intubation tube and then inflating the cuff, even the intubation tubes will have a cuff surrounding them, which is mainly to prevent any air leakage or prevent any leakage from the ventilator, because the patient is not taking any effort to breathe on their own. They're connected by this tube to the ventilator. This cuff will protect from any leakage so that the patient is given the maximum ventilation out of it. So this cuffed airway tubes can actually prevent normal swallowing function, and it can also impact the laryngeal elevation, which is what we talk about in patients with tracheostomy also. So traumatic laryngoscopy, while the anesthetist or the emergency medicine physician is doing a laryngoscopy to view the vocal cords and set the tube in place, they can also impair the hypoglossal nerve, which is important for, which is the main supplier for the tongue muscles. And also the tube compression can cause RLN palsy or paresis. So we had also spoken about ICU acquired weakness briefly before. So looking at what kind of weakness that it could lead to. So if you see the pathophysiology behind this ICU acquired weakness, generally there is also alterations in the muscle structures. So, you know, a patient has been admitted inside the ICU. There are changes in their general systemic changes happen. There can be anabolic resistance. People can have mitochondrial dysfunctions because of, you know, random blood sugars. They can have metabolic issues. There can be some inflammation pathology that's going on, because of which they are admitted. And over a period of time, the patients also develop lack of nourishment because of malnutrition, you know, which can lead to, because of inactivity and lack of oral intake. Because of all of these things, the patient is not being given the kind of, or is unable to accept the kind of nutrition that they need. So the patient needs nutritional therapy, and because of inactivity, the patient needs early rehabilitation. So in this case, it's more to do with early mobilization. Along with this, the patient can also have skeletal muscle loss, strength or function loss. Generally, ICU patients are very lethargic. They're very, they're generally weak by themselves. And it can also lead to cognitive function loss because of multiple changes that are happening in their body. And they can present as ICU delirium or ICU psychosis. By the time this cycle gets down, they go back to their second infection, and which can lead to poor wound healing, again, persistent inflammation that is going on. Wound healing is extremely important when it comes to ICU patients. So if you see how this can have a direct impact on the muscle atrophy and muscle function has been beautifully explained in this slide. So when a patient is admitted, they can have neuronal damage or dysfunction, which can again cause axonal degeneration and leading to impaired perfusion and oxygen delivery, which is again affecting the mitochondrial functions. So all this cellular level of changes and the neuronal level of changes can actually have an impact on the muscle function. It can reduce their muscle function and increase their muscular atrophy. Increase in muscular atrophy is primarily due to immobilization, disuse, mechanical ventilation, and functional denervation. So when we say mechanical ventilation, immobilization, and disuse, it indicates that they are critically ill, where this is not possible. Mobilizing them is not possible. They are not, able to breathe on their own. So that way, in those scenarios, the muscular atrophy is more expected. And in turn, when general muscular atrophy happens, we're also expecting muscular atrophy in the swallowing, structures involved in swallowing. So if we look at what are the central causes of ICU acquired weakness, it can be due to direct damage to the central nervous system, can be because of an ischemia, a stroke, or a hemorrhagic stroke, traumatic brain injury, or inflammatory disorders. Brainstem encephalitis, autoimmune encephalitis, all of these, meningitis, all of these are inflammatory disorders. This again can lead to reduced level of consciousness, which we call as delirium. So when a patient has got reduced level of consciousness, you cannot expect them to, feed orally or give them food orally, because it's only going to worsen the scenario. And it can also be due to drug-induced side effects. So patients who are on intubation have to be on sedation. This can have an impact, like morphine and midazolam can have an impact on their alertness level. We want their alertness to be down. And in turn, after they have come out of that, but still it persists for some time. Some patients can have this presented in terms of post extubation delirium or post extubation psychosis because of the effect that this sedatives and neurotropics can have on their inflammatory neuromuscular junction. So in this, I have like briefly documented what are the different drugs that can cause symptoms of dysphagia, not directly symptoms of directly dysphagia. It can even be an indirect symptom of dysphagia. So esophageal mucosal injury generally is known to be seen in people taking antibiotics, because I'm sure most of us would have taken antibiotics for multiple issues. We are always prescribed a PPI, such as a pantoprazole or esomeprazole, omeprazole, and all of that, because these are generally prone to cause esophageal mucosal injury, which can again trigger our laryngopharyngeal reflux or gastroesophageal reflux, and then inflammation. So it is like a cycle. And sometimes, calcium antagonists, which are generally given for multiple other issues. It could be for potassium chloride for cardiac issues. So these can also have an impact on the esophageal or the laryngoesophageal tone, lower esophageal sphincter tone, or the reflux. People who are on anticholinergics and AS inhibitors, acetylcholinesterase inhibitors, or antihistamines like our allergy medications. If we take our allergy medications, we feel like our mouth is dry, our throat is very dry. So these are generally known to cause xerostomia, which can have an impact on the swallowing. Diuretics, which generally bring down the fluid levels in the body. So these can also cause xerostomia and in turn swallowing issues. And antipsychotic drugs are known to cause xerostomia and in turn swallowing. So these kind of patients can experience swallowing issues. So if you see patients who have just come to us with an acute stroke, so we've diagnosed acute indicates that it's less than 12 hours. So we've diagnosed them, and depending on the location of the stroke, the patient presents with their dysphagia-like symptoms. I'm only going to talk about dysphagia here. So if it's a right MCA territory infarct or a left MCA territory infarct, the presentation is going to be slightly different. Mostly cortical strokes, that is MCA strokes or ACA strokes. First, let me work on MCA. So mostly the MCA strokes generally have decreased level of responsiveness. Their consciousness level goes down because of, they might have an underlying, associated aphasia. They might have difficulty obeying commands. Because the stroke is still evolving, there are changes that are happening in the brain. The patient's consciousness level also goes down. So in those patients, you will find that it is more to do with the initiation of swallow, which gets affected. That is, the patient is not able to do the voluntary phase. The voluntary phase is what is mainly affected. In case of a posterior circulation stroke, such as a brainstem infarct, a pontine infarct, or a cerebellar infarct, or a very well-known medullary infarct, it is more to do with the involuntary phase which gets affected. So it is always important for us to differentiate between a cortical and a brainstem stroke, because the presentation is going to be slightly different. Is it because of the voluntary phase the patient is presenting with dysphagia, or is it because of the involuntary phase, impact of the involuntary phase, the patient is presenting with dysphagia? In those patients with ACA stroke, anterior cerebral artery strokes, it is mostly to do with leg weakness, because ACA supplies lower limb. MCA supplies the opposite side, both upper and lower limbs, and also for the face and the mouth. And so these kind of patients will, ACA territory infarcts, will present with disexecution. They will lose the idea of what they have to do, or they will behave very differently, because of which you might see that they have a difficulty in feeding themselves. They will not be able to feed on their own because they lose the idea. They have executive function difficulties, or something that is otherwise called, even otherwise called as abulia. Abulia is, the loss of ability to, they have the idea, but their loss of ability to do something is what is called abulia. So these kind of issues can also happen. And of course, we've all been mastering about apraxia. So we can also find apraxia in these kind of patients, which can have an impact on their swallowing. So stroke location and physiological deficits is extremely important. So cortical and subcortical connectivity. So any specific lesion which impacts on the cortical and the subcortical connection, more likely to present with increased risk of aspiration as compared to isolated cortical or subcortical. So when both are affected, it's an added problem. If it is either or, then it's a less amount of problem. But brainstem stroke generally leads to severe global dysphagia, and aspiration risk is definitely very, very high. And this damage can also result in weakness or paralysis of one side of the ipsilateral pharynx, larynx, soft palate. And again, it impacts the timing and coordination of the pharyngeal swallow and the upper esophageal control. So all this coordination should happen around the same time. If there is any incoordination, it can have a major impact, which is again is what leading to aspiration risk. So another important area that I want to discuss about is the internal capsule. So internal capsule, again, internal capsule can is more like a relay station from the brainstem to the cortex. And strokes in the area of internal capsule can cause disconnection between the cortical swallowing centers and the brainstem swallowing centers. So because of this, the patients can have difficulty in voluntarily swallowing. And then if you see what is the difference between right hemisphere stroke and the left hemisphere stroke, it has been very well studied and understood that right hemisphere damage, generally patients will also present with visual neglect and anosognosia and all of these things. So because of this, they lose their ability to recognize that they have a problem, and they might take a long time to push the bolus backward and trigger the pharyngeal reflex. So because of that, they can have a delayed pharyngeal transit and increased pharyngeal retention. And there is also, it has also been noted that there is a greater need for non-oral nutrition in patients with right hemisphere damage because of significant pharyngeal dysmotility in all consistencies. These are all some of the research that has been done and very well documented. In patients with left hemisphere dysfunction or left hemisphere stroke, it is more to do with the oral motility dysfunction and reduced coordination of tongue muscles, resulting in poor bolus organization and oral transit. And sometimes it has also been noted that these patients retain the food inside their oral cavity. So already we spoke about the insular cortex. So insula is a hidden cortex. So it is responsible for multiple things. It is mainly responsible for organization of complex behaviors related to the face and mouth. So some bilateral insular cortex strokes presents with Fox-Chavigny-Mary syndrome, which is orolingual, labial, and pharyngeal incoordination. So that actually is a syndrome by itself. It has been identified as one of the most common sites of involvement when dysphagia occurs as a result of stroke. So I want you all to next time look at the image and understand what are the areas that are involved and what is the your assessment findings, so that we are able to collate it much better and understand why that particular patient is presenting this kind of a symptom. So this will help us understand the pathophysiology much better and then deliver the therapeutic intervention accordingly. Another group of patients who can have this acute dysphagia, present with acute dysphagia, is acute cervical spine injury. So cervical spine, again, it is the root which is connecting from the brainstem to the spinal cord, is where the cervical spine is. So it is also has got structures or the nerve roots from the brainstem going into the spinal cord through the cervical spine. And generally cervical spine injury patients are present with more difficult difficulty in swallowing or dysphagia because of the nature of the injury. So this is like C3 to C7 is where our larynx lies, where our airway and all our esophagus, upper esophageal sphincter, and all our primary structures for swallowing lies. So when this area is damaged, so there is a lot of immobility that is happening, the flexibility goes down, and because of which patient will not be able to build the pressure that is necessary to swallow the bolus, and it can lead to aspiration pneumonia, which is one of the leading causes of death in spinal cord injury, especially spinal cord injury. Spinal cord injury, cervical spinal cord injury, because of the location of the injury, they will end up having quadriparesis, which can again impair their respiratory muscles, their mobility, their in terms of they might develop pressure sores, difficulty in wound healing. All of these things comes together, because of which mostly cervical spinal cord injury patients will also have a tracheostomy, which is like a major problem that they go through. So in spinal cord injury, if you see, it is related to the direct neural injury, or it could also be due to subsequent interventions because of the surgery and the spinal implant that is placed. So because of during fixation of the spine, the bone is broken. So the surgeon tries to fix the spine. During the fixation of the spine, sometimes due to the retraction that they do, the nerve can get impaired. Or if it is a crush injury, by the injury itself, the nerve can impair. Or if it is because of, the implant that is put, the spine becomes really very fixed. It cannot move. It is not that flexible, because of which the patients can present with dysphagia. It can also be due to post-surgical complications such as a tracheostomy or an edema. You can find that internally you will see an edema. If we do a fluoroscopy or a flexible endoscopy or a laryngoscopy, we will find that that area is completely edematous, which is causing narrowing of the pharyngeal cavity, and because of which it is very difficult for the food to pass through, and there is a lot of residue. Sometimes these patients might even need multiple surgeries or revision surgeries, and especially anterior cervical discectomy and fusion. Anterior cervical spine, approach to fuse the spine has been, really challenging in treating these patients, because, ACDF generally causes a lot of swallowing issues because of this area involves spinal axillary and the recurrent laryngeal nerve, which passes through, causing a permanent damage and leading to a long-term dysphagia in these patients. So like I already discussed, aspiration, pharyngeal residue, decreased or absent hyolaryngeal elevations, impairments in hyoid displacement, pharyngeal constriction, abnormal pharyngeal wall thickness because of the edema, reduced pharyngoesophageal segment opening, reduced epiglottis deflection, and reduced pharyngeal constriction are commonly observed. And all of these things are primarily our area of interest, because we want all these things to happen so that the patient can swallow easily. But most times it is always noted that these patients, majority of patients, these are expected to resolve at least within 4 to 6 months of their surgery. So looking at what are the assessment, what kind of assessment we do in these patients. So since it is to do with approach, I'm going to go directly, I have spoken about what are the kind of acute illnesses that we see, how it can have an impact. I'm going to move to the assessment briefly, and then we will very briefly discuss about the long-term patients. So primary areas of assessment, if you see, it involves looking at the patient's mental status, nutritional status, respiratory status, oral hygiene and health, postural control, and ambulatory level. It is very, very important for us to see all of these. It's not like I see the patient in the bedside, I just see patient is there. Yeah. Are you okay? I'm okay. Open your mouth, show me the tongue, look at the velum, say E, say U, say your name, and then come out saying patient is okay. No, it cannot be like that, because these are all critically ill patients. It is, we see them on a daily basis. We see them and we document on a daily basis so that we understand how the patient was the previous day and what is the improvement that I see today, and how early I think I can intervene and start and make the patient, feed orally. That is what I am looking at. How early, how safe, and how efficient. These are the three main things that I'm looking at. So if you go through their files, most of the time you will see this mental status assessment basically involves Glasgow Coma Scale, where the patient's eye-opening response, verbal response, and motor response is noted. Eye-opening, if the patient is on sedation, no. But when the patient is brought down every single morning, if a critically ill patient, patient is assessed for their GCS levels. If they are, if their brain sensorium or if their, brain functions are coming out, if they're able to come out of the sedation, is assessed on every single morning. The sedation is brought down and the patient's GCS is assessed. At that point in time, a stimulus is given. It is probably a tap on their shoulder or calling out their name or, pinching them to elicit an eye-opening response and to see their verbal response. In case of a patient with intubation, we cannot get elicit a verbal response. So we write VT or VET. VET indicates verbal response, patient is on endotracheal tube. And the motor response. So as you ask the patient to move their hand and leg, is the patient able to move? Is it on command? Is it only an abnormal flexion to painful stimuli, or is the patient able to extend their hands and legs to painful stimuli, or if the patient is not able to make any movement? Based on that, it indicates whether the patient is alert, awake, or he is still in unconscious comatose state. And in terms of the nutritional status, you assess the type of feeding the patient in. Is there any signs of dehydration? You can see the cracked limbs. You can see their face. You will see that the face is shrinking. You will see one of the very important signs is on their lip. You can see that the patient's lips are very dry and cracked. And also you can see that the patient is malnourished as you see them losing their muscle mass, as you see them losing their weight, and you also ask the nutritionist or the diet team to do a BMI assessment. And some of the acute signs of dehydration includes all of these things. So this we can, it is very, very good for us to go to that extent and learn all of these things. There's nothing harm in learning. And so these are going to tell us about what exactly the patient is going through and at what point in time you have to intervene and what point in time you have to wait. It is very important for us to understand that at what point in time to intervene and what point in time to wait and intervene. And along with that, we will also assess the respiratory status. Is the patient's maintaining enough oxygen saturation? Is he on nasal mask? Is he on high flow nasal cannula? Is he on non-invasive ventilation? How much of a oxygen need is there? Is he maintaining saturation on room air? Is there bradycardia or is there tachycardia? Is the patient having labored breathing? Is the patient having apnea spells? All of these things. Before you ask the nurse or the doctor to remove the mask, you should make sure that you take all these information from the file or interact with them and find out what is the current scenario of this patient. And also, some of the patients might need chest auscultation to understand the kind of breathing. Is there a wheeze? Is there a rhonchi? Is there a low-pitched wheeze? Or what is going on? Is there a lot of congestion? Go through the X-ray and understand if the patient is having a lot of chest congestion. Is there a evidence of aspiration in the X-ray also? Is the patient's cough very weak? Because unless and until we have the adequate support from our respiratory system, we are not going to be able to do our speech and swallowing, which is our primary goal or the primary focus. And make a note of the tracheostomy, the type of tracheostomy tube they are on, how long have they been on, is there a plan to change? During the tracheostomy, have they done a laryngoscopy? What information does it convey? Is there an ooze? Is there a pain? Is the wound becoming bigger? Is there a an active infection surrounding the wound? And how the patient is managing their secretions. Now I remember one of the important points that I wanted to tell with cervical spine injury is managing secretions. Because cervical spine injury, very poor sensation or absolutely no sensation below the level of neck. So any secretion that's coming out of the lung, either it gets accumulated because of the respiratory paralysis or, because of the tracheostomy, it just comes out. It is also equally important for us to understand how they are able to manage these secretions. So is there an oral, are they trying to swallow orally and manage their secretions? Is there a poor effort? Is there absolutely no effort? All of these things is extremely important. Even post-extubation dysphagia, one of the important symptoms which indicates that the patient can have sensory weakness is oral secretions, oral and pharyngeal secretions. When you ask the patient to open their mouth, you can see the whole of secretions just bubbling up over there. So which indicates that the patient is having some sensory weakness. So assessing patients with tracheostomy, again, are the patients able to manage oral secretions? Is there any signs of deteriorating chest? Can you do a cuff deflation? If you want to do, are you going to do a blue dye test? But although this test has got poor sensitivity, but you want to document, we have to document saying, is the patient, aspirating frankly, or is there no aspiration, or is the patient able to, tolerate oral feeds? So this again is going to tell us about doing a detailed clinical swallow evaluation and an instrumental assessment. So some of the indicators for cuff deflation is all of these things. If the patient has adequate level of alertness and does not require frequent oral or tracheal suctioning per every hour, the chest is clear, the patient is able to swallow on his own, and the patient is also able to effectively cough out on their own without even doing a manual tube block. If the patient is able to secretions, if the patient is able to clear the secretions out very well, these are all positive indicators for cuff deflation. So you have to deflate and see. Basically, it is like you deflate for a short while, you observe all these things, and then you give the orders for deflating the cuff periodically at what point in time. So if the patient is not able to maintain alertness, they still need a lot of suctioning, poor chest condition, there is no spontaneous follow, you see that a lot of secretions are there in the oral cavity, cough is ineffective, so better don't recommend to go for cuff deflation. And one of the other important things that we need to, it is very, very, very important for us to look for is the oral health and oral hygiene. This is a very simple assessment, Beck oral assessment scale. So this tells us about what level, what is the score, and it also tells about what intervention that needs to be done below depending on the score. You can all go through this. It's very easy. You can all do it on each other or on all of your patients. I'm sure you all must be already doing these things. So this is very, very important. So before doing a clinical swallowing evaluation, these are the musts, which is what we are talking now. So evaluating the oral health, especially on patients who are on endotracheal tube, oral and oral hygiene, although the staff nurses will maintain or give them the necessary oral hygiene regularly, but still because the tube is there, there is always collection of saliva surrounding the tube. This can cause a lot of bacteria growing, which is the main reason for developing of ventilator-acquired pneumonia or hospital-acquired pneumonia. So if oral health and hygiene or the tracheal tube health and hygiene is not maintained adequately, it can eventually lead to pneumonia. So some of this, quick procedures, I'm just going to quickly go through all of these things. Quick procedures to identify patients at risk is by screening. So this can be done by a physician, a nurse. If an SLP is available, very well. At all times, 24 hours, none of us want to do a 24-hour shift, I hope. So whenever we are available, we do it. If, we can also always train the staff nurses just to identify, what they're going to do is only a screening. We're not going to train them to become another SLP. We're only going to train them to do a screening and tell us whether, our intervention is needed. It is always important. And we also follow some protocols in our hospital ICU and for our stroke patients and for our neurosurgical patients, even for transplant patients. We have strict protocols which are in place that post-extubation, every patient post-extubation is screened for dysphagia by the SLP because we are available here. So one of the interesting or a very basic ways of assessing is the repetitive salivary swallow test. You ask the patient to dry swallow for 30 seconds. You assess how many times they're able to swallow. This is a very not so sensitive test, but a very simple test. The next one will be the 30 ml water swallow test, which will tell us about, whether there is any risk of aspiration. So I also have this thought which I want to share now. Every time a patient chokes or coughs, it doesn't mean the patient is aspirating. And every time the patient does not choke or cough does not mean that the patient is swallowing well. We really don't know what is the physiology that is going on, because we just spoke about sensory weaknesses, motor weaknesses, multiple other systemic issues. So all of these things can have an impact on the swallowing musculature also. So it is not that you conclude that the patient is not choking. That means there is no aspiration. I don't want to, any one of us to hear, say that to the patient or discuss. signs of aspiration or overt aspiration signs are not there. So I just want to try. I want to initiate orals and see how the patient is tolerating. No patient is going to aspirate 1 ml of water and immediately they're going to develop pneumonia. Any pneumonia, aspiration pneumonia, takes its own course of time because the bacteria also takes some time for it to grow and multiply. So it is important for us to go stage by stage, step by step, and then see. So these are all some of the indirect ways of assessing it. So 30 ml water swallow test will tell us about whether the patient is able to, sip and hold the water in mouth. Is there any escaping of water? Is there any, patient is trying to forcefully drink the water? Is the patient able to do it in one gulp? Is the patient is unable to do it in one gulp? How much? All of that. These are all some of the indirect ways of assessing. Again, 3 ounce water swallow test, hose swallow, wet hose, gurgly voice quality will give us a brief idea about, okay, this patient probably is having an issue. This patient has post-swallow gurgly voice, which indirectly tells me that the patient is having some amount of residue. So I'm asking the patient to swallow again. Is it clearing? No. I do a cervical auscultation to listen. Is it clearing? No. So maybe the residue is still there. So the chance of risk of aspiration is much more high. So there is also this gugging swallowing screen, an ICU version of it, where they have included this Strider component and also the RASS component. So these also will tell us about, I think you all can go through this in much more detail. This will also tell us about what is the scoring and what to start, where to wait, what to do, what not to do, what points to give, what intervention needs to be done, whether the patient needs to go for a modified diet, is the patient requiring an instrumental assessment, if so, what type of an instrumental assessment, or the patient needs a enteral tube feeding. Also, MASA in the ICU, it is a short screening. The other one is a long one. This is a short screening one, which will just tell us about what exactly the patient is, what level the patient is. Is the patient having no abnormalities? Is he in moderate, mild level? Can we initiate food? What type of food we can initiate? So this is again a very handy and a very comprehensive assessment. Of course, flexible endoscopic evaluation of swallowing, where you give bolus and you try to assess the symmetry of the laryngeal, pharyngeal structures, and then at rest, and then you give them some tasks. You look for the breathing, swallowing coordination. You look for the vocal cord adduction during breath hold. Is that vocal cord adduction enough for initiating oral feeds? Is there a phonatory gap? Is the patient able to swallow? Is there whiteout? Is there post-swallow residue? Is there post-swallow aspiration? Is there pre-swallow spillage? During swallow is one of the disadvantages which you cannot assess in fees. So it can only tell us about pre and post-swallow. During swallow, because of the whiteout, you are not able to assess that. And the next thing is the video fluoroscopic swallow evaluation, where we evaluate the patients on all the parameters, beginning with the lip till the stomach. So it's always important for us to, understand what is going on with the stomach also. Is there a gastroesophageal reflex? Is there a retention? Is there a delayed clearance? Is that going to cause an impairment? Is that the risk for aspiration? Is the patient able to follow the commands that you're giving? Is the patient able to execute the compensatory and the facilitatory maneuvers that you're going to train them on? Is it effective? How effective is it? What more needs to be done? What kind of modification? Is the patient able to maintain the posture? Is the patient able to, obey what you're saying? Everything put together is going to be the gold standard video fluoroscopic swallow evaluation. I just have one single image of video of a patient with lateral medullary syndrome. So this patient did not choke. This patient did not cough. But when we did a video fluoroscopic, this is what we found. So you can see there is penetration into the larynx. There is so much of residue on the vallecula. The food is not at all going down into the esophageal sphincter, below the esophageal sphincter at all. It looks like it's going down, but it is still coming back because the pressure is not enough to initiate that upper esophageal opening, because the cord is not able to relax. The hyolaryngeal elevation is impaired. So this is why I said, because the patient has not coughed, it doesn't mean the patient is swallowing. And because the patient is always coughing, it doesn't mean that the patient is aspirating. So if you look at people in the long-term care, excuse me, So we're looking at elderly patients. That is what I'm going to briefly discuss about. So as people age, swallowing physiology also changes. So because of the reduction in the muscle mass and the connective tissue, it can have an impact on their loss of strength and the range of motion. If you see our own, we will have grandmothers and grandfathers in our house. You see the way, they have been doing about 10, 15 years when you were a child, and when you grow up as an adult and you observe their general pattern of work routine or their day-to-day activities, you see that their strength goes down, their range of muscle, the range of movement. It could be their motor movements, it could be their physical activity, it could also have an impact on their swallowing. So this in turn has an impact on the effectiveness and the efficient flow of the swallowed materials. So if you come across such kind of people, you will generally tend to see that they take a lot of time to prepare their food. And over time, this can be very, very debilitating for them, because, when they take a long time to eat, it can actually have an impact on the nutrition that they are gaining. And also this can, because of accumulation or because of inefficient swallow, there can be food materials that will be penetrating into the airway. They can be smaller food materials, and they can also, apart from the motor impairments that we are discussing about, they can also have sensory impairments in the form of reduction in the oral moisture, taste and smell. That can also have an impact on their swallowing performance. Added to all of this, they can have some sort of a primary factor contributing to dysphagia. It can be something like an age-related cerebral atrophy. It can be a Parkinson's. It can be a diabetic neuropathy. Diabetic neuropathy does not affect the swallowing muscles, but because of the generalized weakness or generalized other peripheral issues that they have, this can also have an impact on their feeding. So in people with dementia, generally people with dementia have a slow thought process. They are not able to, be on par with other people around them. So they also have a major impact, but where they demonstrate slowing of their swallowing process. So they take a long time to finish a meal, and because of which they end up having poor nutritional status, and they have difficulty self-feeding. They keep the food in their mouth, or they don't know how to swallow, or they are spilling all over. They have forgotten that they have to eat the food. So all of these things can have difficulties, can present in the form of difficulty in swallowing and poor nutritional status. Sometimes they can even have loss of appetite or avoidance of food. So you would have heard that people always say that there can be cravings also. They would have just had their food like 30, 45 minutes back. They again ask for food, saying, oh, no, I haven't eaten. You have not given me the food. They end up fighting with their family members, saying, you're not taking care of me. I'm not given the kind of food that they want, and all of that. These are all because of decreased perception, decreased sensation. And this can also have an impact on their weight loss. So weight loss and decreased nutritional status. Why do we say eat healthy, maintain your body, maintain the nutrition? Is because you are building your body to fight against infections. So again, weight loss and decreased nutritional status, and added to it the slowing process and difficulty and inefficiency can have end up with them having pneumonia, which is one of the main reasons or causes for their death. So how are we going to manage this dysphagia? We manage dysphagia by forming a multidisciplinary team with the ICU consultant, the critical care physician, the staff nurses or the head nurse, the emergency medicine physicians, the neurologists, neurosurgeons, and the primary surgeons, primary care providers, who can be any of these general medicine physicians. So you form a multidisciplinary team along with the patient and their family member, so that they also understand that this is an important aspect which they have to pay attention to. Because most of the times we see patients coming in and telling us, when are you going to remove the tube? When is the patient going to start swallowing? It is our duty to educate them and tell them that we are trying to do it at the right time and in the right pace, so that the patient is free of any issues which can probably recur, and they will end up coming back to the hospital for admission. Yeah. And also managing their swallowing based on the symptomatic management and compensatory measures or maneuvers and diet modifications, and provision for alternate nutrition. So all of these things put together is what is generally is done in patients with acute illness and for patients with long-term illnesses. So that's it. Thank you. I hope I have completed within the time slot given to me. I'm sorry, I can't hear anybody if someone's talking.
Hello.
Yes.
Thank you for a very interesting and comprehensive presentation. Thank you for highlighting the effect of various etiologies at the cellular and muscular, neuromuscular level as well. And also, one more key takeaway from your presentation I would like to highlight is that in acute care settings, we have to assist the patient every morning.
Yeah.
So that is challenging for us. Correct me if I'm wrong, due to spontaneous recovery, we have to keep.
I'm sorry, I didn't get the last part of what you said.
Due to spontaneous recovery that might be happening in these patients, we have to keep monitoring them or assessing them on a daily basis.
Yes, there is, see, recovery happens on a day-to-day basis. It is not something like it happens on its own spontaneously. The treatment that is being given in the ICU or the acute, during the acute phase itself is for recovery. During that phase, every aspect of the patient has to be taken care of. So it is our duty to go and assess the patient on a daily basis to understand how it was the previous day and today and what changes has been made, which is causing this. So that also makes a lot of sense. So they will also understand that because of this patient had an impact on this particular function. So I think I need to cut this down at this level. So just like, you know, how, in the audiology sense, using a ototoxic medication. So a patient undergoing chemotherapy, the chemotherapeutic drug is ototoxic. So you do an audiometry and you tell them that, the patient has started having a hearing loss. I think this is the time you need to stop, or you need to make sure that you adjust the dosage. The same way here also it happens. So it is also important for us to go through the drug chart. It's not something like, drugs is not for us. We are not meant to see the drug chart or anything of that sort. So we have to go through, only then we will also understand what impact, what is having. And as a discussion, when we go back and tell them, it makes a lot of sense for the primary care provider also to, put all the dots together and see the puzzle as a whole picture.
Are there any questions from the audience? Good afternoon, ma'am.
Yeah.
Is there any time for GCS score and level of SPO to start a sudden evaluation?
Sorry, is there anything for GCS score?
GCS score and SPO2 level to start sudden evaluation, like below this level, it should not be this level.
Yeah, so SpO2 levels below 95 is considered, on room air below 95 is considered as desaturation. So GCS score should be minimum 8. Basically, we're looking at, is the patient able to be alert, spontaneously open their eyes, that is E4, and patient is able to obey commands. Yeah, these are the two main things that we look at. So GCS minimum should be 8 for us to do an evaluation.
Okay, thanks.
Hello, Dr. Singh.
Yes, sir.
Yeah, so it's very good lectures and we have learned a lot from you.
Thank
And
you.
I'm sure that students who are participating, including the online, some other colleges, all are benefited much about your lectures. Here, just one thing I'd like to know from you. the kind of assessment and display assessment when we are doing in the clinics or the hospital. What are the different support staff or any other arrangements setup is required for assessment or such display, various types of dysphagia at the clinical levels, hospital levels, what kind of support staffs or any other extra arrangements required? Can you highlight?
Sure. So, in any hospital, definitely we will have a staff nurse. So a staff nurse is definitely needed because when we go to the ICU, mostly ICUs are all one-on-one. So every patient is assigned with one staff nurse. So this staff nurse should be briefed about the protocols that you follow so that they are able to, support in terms of what are the needs. Like you might need, some of the for evaluating, you might need a sterilized tongue depressor, might need a sterilized glove. So they will need to be there to provide you with that. And also radiographers, because to perform video fluoroscopy and evaluation and all of that, radiographers, you need to be in good rapport with them, radiologists and radiographers, of course. And apart from that, yeah, so mobilization, for mobilizing a patient from the bed to wheelchair when you want to assess, or to make the patient sit on the chair and you want to assess the patient, you might need the help of a physiotherapist and a staff nurse. So these are the support staff who will actually be of great importance in the team for assessing from our perspective, I would.
Good that you have
Thank you.
informed. Regarding the pediatric solvers, the mothers who has finding difficulty to solve for their infant or babies. So the pediatric solver I'm talking about for the children. How you are advising the mothers in terms of overcoming such problems, feeding problems, swallowing problems for the children. How you are advising the mothers how to overcome such problems.
Okay. Sir, if I understood your question right, in feeding and swallowing problems, how you advise the mothers? Is that what's the question? Okay. So we see babies in the NICU, premature babies who are born 4 months premature. Okay. Sir wants to know about pediatric swallowing and the mother counseling. Okay. So 4 months premature, 3 months premature, who've had like a great time living, and they're just coming out of their course in the hospital. So we've primarily work on telling the training them to do the sucking and suckling, because that is something which they don't learn or they are not able to efficiently perform, because of which their feeding becomes a major issue. And also for other babies who have had multiple high risk factors like hyperbilirubinemia or hypoxic ischemic encephalopathy, who are at risk for developing a developmental issue, we, while doing the hearing screening or a developmental assessment, we do a developmental assessment at 3 months, 6 months, 1 year of age. We follow them up regularly from screening to 1 year of age. Every single time when they come, we are assessing their motor, speech, swallowing, cognitive, and their general global development as such. And then we advise the families to train them on what are the parameters. So basically, we are not trying to panic these mothers also. We are only trying to tell them that these are the parameters that you need to work on. So it could be something as simple as giving them nipple to elicit the suckling response, or giving the stimulation around the buccal area to elicit the rooting or the suckling reflex, and to give them the feel of holding the mother, and all of these things. The very, very, very simple ones, the very primary things, but all of these things definitely make a lot of difference, because this is actually making the child feel more attached to a person, because as the child is developing from the NICU, after having gone through so much of medical issues with tubes hanging all over the place and all that, they are at so fragile. So giving them the chance of, interacting with people and making them be a part of us actually plays a major role, because most of the time the demand from the environment goes down, because parents also feel that the child is such a fragile child. I think I shouldn't be doing these things. I think I should just protect the child. In the course of protection, the child is lacking what the child needs. So we always educate them to make them understand that the child needs the mother's care, and the child needs to be, following all of these things. The mother needs to follow all of these aspects so that the child can overcome these feeding and swallowing issues also. And primarily it is to do with oromotor stimulation and feeding stimulation. So it is to, because there the brain development is also still evolving. The brain is not fully developed for us to make the child relearn something. Making a person a developed brain relearn is a lot more of a task. Here the child's brain is still developing. So this, the child will compensate very well. So due to the plasticity that is going on. I think there is some question on the chat box.
Yes, ma'am. What are the differences in symptoms in case of insula versus cervicospinal lesion?
Insula is more of a cortical. So like, it is more to do with the initiation of swallow. So anything cortical leads with, think of, if you divide it between voluntary and involuntary phase. 1 second, I'm sorry. Aishwarya, can I call you back in 10 minutes? Yeah. So when you think of the voluntary and involuntary phase, cortical structures control the voluntary. So the signals that have to reach from the cortical structures to the jaw, to the lips, to the tongue, to open and to do the chewing act, that is what is primarily affected in insular lesions. And in cases of cervicospinal lesions, which is the, I would say it is more to do with the corticospinal tract. So corticospinal tract lesions, it is more to do with the cervicospinal. If you say the lesion is over here, it is beyond the element. So it is more to do with the pharyngeal structural lesions at the level of the pharynx. So that basically affects the pharyngeal phase of swallow, leading to increased risk of aspiration. Both has equal risk of aspiration, because if I have not processed my food well, if I have lost the ability to initiate swallow, the food is going to go haywire, and my laryngeal and the pharyngeal system is not ready to take the food, and the food is going to just sit there. After some time, because of the movement or because of late response, I can still end up aspirating. And those patients are at higher risk for silent aspiration also.
Thank you, ma'am. There is one more question. As a medical SLP, who makes the bulk of patients that you see? Whether it is those who require acute care or long-term care?
No, your voice is breaking. I'm sorry. As a medical SLP, who?
What kind of patients do you see more in your practice? Whether those who require acute care or long-term care?
Okay, so I have been working with acute and long-term care patients. I've been seeing patients, babies, to developmental disorders, to acute patients in the ICU, to post-stroke, neurology, to neurosurgery, to patients who are requiring long-term rehabilitation, like patients post-stroke who have crossed the acute phase but require like a proper 2 months, 3 month rehabilitation also. So it is like widespread. I can't say like I see only acute, I don't see long term. So it is all over. I know I see all kinds of patients on a regular basis.
Thank you, ma'am. So this would underline the scope of SLPs in assessment and management of this dysphagia.
Thank you so much. Thank you for the opportunity. Thank you for patient listening and wonderful interaction.
Thank you for taking the time out.
I think we have to give the credits to Abhishek because he finished before time, because I am always outside. I'm always beyond time.
Thank you, ma'am, for sharing your
Thank you.
knowledge.
Thank you,
Thank you
sir.
for your
Thank
time.
you. Thank you, Rajan sir, and thank you, Arun Panik sir. Thank you, everyone.
Thank you. I would like to call Ms. Roshni to announce the prize winners for this competition. I would like to call upon Subhanar sir to issue the certificate to the students who are running this competition. So the winners are group 5, that is Nitishri, Abhika, Deepak, Divyadashmi and Ritesh. Thank you, sir. Next, I will call upon Rajan sir to issue the certificate to the runner-up. I would like to call upon Sindhuja. They are very closely to the winners. Kavita, Chandana, Daniela. Can we have a look? Participation certificates for all the students who have participated in the quiz will be given in the department. Next, I will call upon Lakshmi Priya to deliver the vote of thanks. Good Good afternoon, everyone. It's an honor to have the opportunity to express my gratitude to one and all present here. On behalf of Department of Speech Language Pathology, School of Rehabilitation and Behavioral Sciences, I would like to express my gratitude to the resource persons of today's webinar, our Dean Director, all faculty of SRBS, and student participants for supporting this event. First, I would like to thank our eminent speakers, Dr. Abhishek, Assistant Professor, All India Institute of Speech and Care in Mysore, and Ms. Srimati Narasimhan, Head, Center for Hearing, Communication and Cerebral Sciences, Dr. Rila Institute and Medical Center, Chennai, for accepting to be the resource persons for today's webinar and their brainstorming session on aphasia and dysphagia. I extend my gratitude to Professor L.V. Rajan Sir, Dean Director SRBS, for supporting us in conducting this webinar and this program on application of aphasia and dysphagia awareness. Thank you, sir. I would like to thank Professor Dr. Arun Vani, Head of Department of Speech Language Pathology SRBS, for believing in and supporting us in organizing various events in view of aphasia and dysphagia awareness month. I would like to extend my thanks to Dr. Subbarao, Professor, Department of Speech Language Pathology, Dr. Rajlakshmina, Head of Department of Audiology SRBS, and Dr. Pratnya Patna, Professor, Audiology, for placing the application by their presence. Thank you, sir. I also like to express our heartfelt appreciation to all the dedicated faculty members of SRBS and special mention to Ms. Radhika ma'am, Dr. Amelia ma'am, Mr. Rajesh sir, and Ms. Ashmita ma'am for making this event grand success. Thank you, ma'am, and thank you, sir. I congratulate the winners of SLP Knowledge Fund as well as the participants for their active participation. Thank you everyone once again for making this event grand success. Thank you.
Can we leave?